So welcome to this afternoon today and a very early evening from salutations from Alwar, Bharatpur and Ganganagar societies present RH negative pregnancies for a talk and a panel. This program is sponsored by the Bridging Bharat initiative of Bharat Serum, and we have a galaxy of stars today. So first I would like to introduce the convener for the program, Dr. Leela Vyas. Welcome very much, madam. So Dr. Leela Vyas is a senior consultant at Cocoon Hospital, Jaipur. She is also a consultant aesthetic and cosmetic gynecology at Vyas Clinic, Jaipur. She's been the vice president of Foxy, president Narchi, Rajasthan, president Jaipur Obs and Gynae Societies for 2 terms, and she has won excellent awards and a very wonderful personality. Dr. Leela, thank you very much, and might I request you to introduce the chairperson.
Thank you, Jason, for your kind words. Welcome everyone for this webinar, and really I am thankful to everyone, and on this short notice everyone was ready, and that's why I say that this is the young brigade. They can work short, hardly of 24 hours, and they are ready to conduct this webinar. Hope and all the best for this successful webinar. And really I am thankful to Alwar, Bharatpur and Sri Ganganagar Society. From Alwar, Madam Sarojan, she is very kind enough to agree on this short notice, and she has informed her all members about this. And Akriti, very active secretary, she is also involved in that. Bharatpur, Dr. Dinesh, really I'm convey my sincere thanks from my side and also from the Bharat Serum. And Sangeeta is always active. If you call her, that she is ready for doing everything. Sangeeta, congratulations and all the best for doing all these work in future. And from Ganganagar, Madam Parvinder Kaur, Madam, thank you for joining this webinar and for this informing your society members to attend this. And Savita is always very dynamic and she is ready for everything. You call her that Savita ye karna, she is ready for doing this. So thank you all 3 societies for joining this webinar. And this topic RH negative day to day in this practical point, we should know about these things. And to go back on that, if RH negative you talk with me, I remember 2 things. One is the science fiction written by author Henry, that is Final Diagnosis. That I have read in mid 70s when I read this book. I think it's published in the late 60s and all. That time they have doctor missed the diagnosis of that RH negative group, that they have informed that, and it's a very nice book. And it was in our young time that when we were started to read these science fictions, when we entered into the science. Our time is that in the 9th standard we have to take the subject, whether we go in the art or in science, and we have science in 2, whether you want to go in bio or you want to go in maths. So that was the only time that I remember. Another thing from my undergraduate time, that RH negative we used to remember in recurrent pregnancy loss, the RH negative comes under the descending orders of the loss. So, but the time has been changed. We can't say that RH negativity but it can be a cause of that recurrent pregnancy loss. We have that options. We have that treatment options available in utero also and post delivery also. So we all young brigade of these fetal medicine persons, I congratulate you, welcome you all for this type of webinars. And my this will be always, I am interested to bring all these youngsters to come forward and present their work. And definitely I am very thankful to Dr. Satyen. So we need always, the fetus is in utero up to is our patient, but afterwards it goes to you, and we need always your help. And also at the basically antenatal part, we should talk to you that we are doing this and how you will take forward to this baby. And another person, that Dr. Ravi, he is immunohematologist, because which type of antibody, because we always say, "Arey bhai, iska to titer itna kam tha," and she responded, but iska high tha, she has not responded, or the low titer has not responded and high titer has a good output. So this all will be by the hematologist, immunohematologist, they can know the immunity and type of the antibodies. So with this, I hand over this mic to our chairperson. Our chairperson, Dr. Archana Verma, you all must be knowing, not from that, since 1916 to 19, her tenure was as a public awareness committee chairperson of Foxy, and she is the one who has joined everyone Foxys from all the grassroots level. She has collected everyone and she runs so many programs, and everyone knows her as a very active Foxian. And at present, she is having associated with so much of these activities. But one is now she is a vice president elect 2020 21 North Zone vice president. And Dr. Archana, all the best. So next year, I think we will be not only on the virtual meetings, we should have that actual meetings also. So Dr. Archana, welcome, and thank you very much for accepting our invitation to become a chairperson. The second chairperson, Dr. Pratibha Singh, she is, I'll say, the young, dynamic professor and head of All India Institute of Medical Sciences, Jodhpur. So Rajasthan's first, and she is heading a very dynamic personality and always interested in the academics. And thank you very much for joining this webinar as a chairperson. And now this stage is for you. Dr. Pratibha, please introduce our, to take this further webinar further forward in this. Thank you very much. Session, put the slide of speaker.
Yes, madam.
Session is unmuted.
Madam, might I request Dr. Archana to formally introduce Dr. Sonia Mean?
Very good evening, everybody, and I'm really thanks to all the organizers for inviting me here to join and be a chairperson. It's really honor to me, and thank you, Dr. Leela Vyas. So, Doctor, this RH incompatibility and is really close to my heart. And when I came to know that this is going to be this topic, I really and readily, very easily accepted it. And because there are so many problems and such a easy way to conquer this disease. So we will be hearing it in this webinar only. Though it looks very difficult and we sometimes we may lose hope also, but if we do the awareness, if we are aware and if we are taking precautions, nothing can bad can happen. And I hope you will be very happy in the end of the webinar. So now I'll invite Dr. Sonia Meal. She is a director of consultant fetal medicine, and Dr. Sonia is having her own sonography clinic and advanced center for fetal medicine, Jaipur, and she is has a fellowship in fetal medicine from NHL Medical College, Ahmedabad, and ICOG. Fellow in ultrasound, and she's a MS in Ops and Gynae from NSCB Medical College, Jabalpur. Oh my God, Jabalpur is so famous. And she did her MBBS from BVP Medical College, Pune. And so, welcome Dr. Sonia to throw a light on RH isoimmunization.
Thank you, ma'am. Thanks a lot for your kind introduction. And first of all, I'd like to thank you everybody who gave me this opportunity to talk on this topic. No doubt the topic of RH negativity is quite vast and the time allotted is a bit short, but still I'll try to make the justification of this time and will try to cover all the relevant points in this talk. And I'm lucky enough to be preceded by the case-based panel discussion. If by chance I leave something or I cover it in brief, it will be taken care in the panel. Thanks a lot. Thanks a lot again. Can I have my slides, please? Shashank, can I have my slides?
Madam, you had shared it from your computer. May I request you to press the share screen button so that you can share the
Okay.
PPT?
There's a green button down.
Okay. Is it done?
Madam, we can see your slides.
Okay, thank you. So let's start with the management of the rhesus negative pregnancy. First of all, coming to the epidemiology, not wasting much time on this, I'll just tell you that the problem in few countries it's very high, but luckily in India it's up to 5 to 7%, and that is more even in the Gujarat belt, Sindh, and some borders near Pakistan. And in India, we have this limited 5 to 7%. Now, coming directly on the pathophysiology, first of all, I like to tell you that we know about the two common blood group systems. One is the ABO system and other is the RH system. ABO blood system comprises of A, B, AB, and O, and the rhesus system consists of C, D, E, and G. In this, we are mainly concerned about the D antigen. Why D? Because we don't have any small d form, and this D is the most immunogenic one, and all the problems related to Rh negative pregnancy is related to this D antigen. Now, how these antigens are present on the RBC, we can see in this. We have a RBC with presence of A antigen, B antigen, and this is how the Rh antigen looks. In case of Rh positive person, they have these antigens on the RBC, whereas the one who's Rh negative won't have these antigens on their RBCs. Now, as we are talking about Rh negative pregnancy, how it's important for us. Rh negative mother means she has no capital D in her chromosome. The genes for this Rh factor is located on the chromosome 1. We have two arms of the chromosome 1, and the zygosity of this, the genotype of this D matters to us. How it matters is very important, because when this D antigen is present, based on that, we have heterozygous and homozygous. Who are the heterozygous? Heterozygous are the one who will have this gene on one arm but absent on other, and homozygous are the one who carry these genes on both of their arms. Now, the one who's heterozygous, whose partner is heterozygous, they have a chance of 50% pregnancies being Rh negative and 50% Rh positive. So they are safe 50% time they are just like other antenatal patients, but in 50% times they may have to face this Rh negativity problem. Whereas when we come in the case of homozygous state, it is that all the pregnancies will be affected by this Rh factor. Now, this is a flow diagram by my sir, Dr. Prashant Acharya sir, and my aim of further slides will be to make you comfortable with this flow chart, because this flow chart is going to help you in deal with your antenatal patients. This will give you a fair idea where to do what, where to advise what, and where to intervene. Now, as we are talking about alloimmunization, first we should know what is this alloimmunization. Alloimmunization is a condition in which antibodies develop into the body against the antigen of the same species. For example, as we are talking about Rh negative mother is the one who is not having any antigen in her body. But when she is exposed to these antigens, Rh positive antigens, her body will make antibodies against them. And this reaction is known as Rh alloimmunization or isoimmunization. There are only two basic mechanisms by which any Rh negative females can become a Rh positive, alloimmunized. One is the history of any blood transfusion of history of any incompatible blood transfusion, and second is the feto-maternal hemorrhage that occurs once she is pregnant, and that too with the incompatible fetus. The fetus in that case has to be Rh positive to create that alloimmunization in the maternal blood. Now, coming to this feto-maternal hemorrhage and Rh incompatibility, we should know the amount of the blood that might lead to this sensitization. It's said that as little as 0.1 ml of Rh blood can lead to this, but studies have shown that a minimal amount like 0.03 ml can even lead to this Rh positivity. And there are few lucky persons, 30%, who, in spite of when challenged with a large dose of Rh positive blood, they won't develop any antibodies. Now, how this alloimmunization mechanism starts? As I told, one thing was the history of any incompatible blood transfusion. Second is the feto-maternal hemorrhage. Many of us think that feto-maternal hemorrhage is something which takes place only during the time of delivery. Yes, it's true, as the 90% of this will be taken will occur at the time of delivery. But if we think so, then we are missing those 10% which occur during the time of delivery. And this during the time of pregnancy, it is different in each trimester, but it is there in every trimester, like 7% in first trimester, 16 second, and 29% in the third trimester. Now, how this is useful for us? Because many of us think that if any lady get aborted by 8-week pregnancy and we didn't do any instrumental intervention, then why to give her the NTD dose? In this, I would like to say that the mechanism of erythropoiesis in the fetus will start from the day 38. When on ultrasound we start seeing the yolk sac, it is the time when the erythropoiesis has already started into the fetus, and the sensitization and the rare chance of sensitization of maternal blood can occur due to early abortions in which no instrumentation even was done. So be careful when we come across any such early abortions or history of any subchorionic hematoma, early pregnancy bleed. We should always cover them with the NTD. Now, how does immunization start? First, whenever a maternal blood comes in contact with the fetal RBC, which carries the Rh antigen, the maternal immune system start forming the IgM antibodies. As we all know, these IgM antibodies are large enough and unable to cross the placenta. So this IgM antibody will take around a week time to develop in the maternal blood, and subsequently it will lead to the formation of IgG antibodies, which will take around 6 weeks to 6 months time, and these IgG antibodies the size is small, so they are the one who will cross the placenta and will destroy the fetal Rh positive blood. Therefore, usually we see when when a primary female delivers and no Rh NTD coverage is given to her, her first pregnancy will be really uneventful, because these process of this IgM, IgG formation takes time. By the time she delivers her first baby who is healthy enough, but this is the time when she was exposed and IgG developed in her blood, which is going to affect her subsequent pregnancies. Now, why we are worried about these development of these antibodies? Because these antibodies, as I told you, IgG are small enough to cross the placenta, They will enter into the fetal blood. They will get attached to the Rh antigen on the Rh positive blood of the fetus, cause hemolysis of that blood, subsequently leading to fetal anemia once the hematocrit is less than 30%. Now, when this hemolysis of fetal RBC occurs, there is a heme formation which will convert to bilirubin, lead to fetal hyperbilirubinemia. As we know, it's a neurotoxic, but certainly when the fetus is intrauterine, it will be taken care to some extent. Mind you, I'm telling you to some extent, though it's going to affect the fetus, it will be taken care by the placenta and the metabolism of mother. Also, it will cause extramedullary erythropoiesis stimulation. This will lead to hepatosplenomegaly. Immature erythroblastosis will come in circulation, and if still not taken care, this will lead to a severe anemia, hepatosplenomegaly, thinning of the blood, less oxygen will be delivered to fetal cells, which will lead to ascites, edema, pericardial effusion, and eventually the heart failure. And once the hydrops fetalis occur, when the hematocrit falls below 15%, then there might be a high chance of intrauterine death, either intrauterine or after birth. So this is the diagrammatic representation, what I have explained you till now, that a Rh negative mother, when the partner is Rh positive, they have the chance that the fetus is Rh positive, and when the feto-maternal hemorrhage occurs, there is sensitization of the mother by this Rh positive cells, leading to the formation of these antibodies. These antibodies will in subsequent pregnancy will cause hemolysis of the fetal RBC, leading to fetal anemia, heart failure, and subsequently the fetal death. So, coming to the percentage, that how this Rh sensitization risk occurs, that if a female is exposed to Rh positive antigens, and 16% she will get sensitized after her delivery. And why it is important for us? Because she was not no prophylaxis was given to her. But if we give a postpartum prophylaxis, we can reduce this 16% to 1 to 2%, and with administration of antepartum along with this postpartum prophylaxis, we can even reduce these percentage to 0.1 to 0.2%. So we can see to what extent it is manageable, it can be preventable if we are aware and we make the patient aware regarding this. The sensitization occurs mainly by the amount of the transplacental hemorrhage, the amount of the feto-maternal hemorrhage, the maternal immune system, and if we are lucky, if there is some concurrent avio incompatibility, this acts sometime in a protective way. So the Rh incompatibility is the medical concern for females when they get pregnant. Now, coming to the management part, whenever we such patients comes to our clinic, our management starts with a detailed history itself. The history being any history of blood transfusion prior, and simultaneously we have to see the ABO-RH blood group of the patient and the spouse. All previous pregnancy, if she has, need to be documented in this. If she has any early abortion, any invasive procedure, any intervention was done in previous pregnancy, they should be noted. Any history of hydrops, that is very important, because once if a lady has hydrops, there are 90% chance of its recurrence. So that should be taken care, that should be always asked. Also, we should know if NTD was given or not, because even if some females have a history that they were given the NTD and in spite of them they are sensitized, Then what may be the cause? The cause is the inadequate coverage. Inadequate dose was given. It was not measured with the feto-maternal hemorrhage. We just gave the blanket dose of 300 micrograms and we were happy that we have done the prophylaxis, but no, this was not the right method. So as I told you, we should take a detailed history of abortion, because some patients coming to our clinic, they are telling, yes, this is their first pregnancy. They will hide you any pregnancy which they have taken some abortifacient drugs over the counter. And many times patient usually rarely disclose such kind of abortions. But when it comes to Rh negative, these should be insisted, the importance of this should be told to the patient, and then the detailed history regarding abortion, any invasive procedure, abdominal trauma, any antepartum hemorrhage in previous pregnancies, intrafetal demise, multifetal gestation, manual removal of placenta, ectopic pregnancy and cesarean delivery to be taken care, because there are few conditions in which the amount of feto-maternal hemorrhage will be more and our blanket dose of 300 micrograms won't be enough to cover all these things. So we should be aware of these things, that if this inadequate dose has led to the sensitization or the NTD was not given, that's why she is she is sensitized. Now, once the antenatal management starts, the antenatal management can be of two types. One is prevention, other is management. Prevention we can use for the one who has the indirect Coombs test negative. It means that they are not yet sensitized, and we have time, we have maneuvers so that we can prevent this isoimmunization in them. But for the unluckily, if somebody is already ICT positive, already has been exposed to these antigen and antibodies have developed, in that early detection and treatment will going to help us. So the aim of the antenatal management is first to know the maternal immune status. If the mother is not immunized, then prevention of isoimmunization. If the mother is immunized, the aim is to detect the fetal anemia or hemolysis and to prevent the fetal complications. Rh negative mothers are special not only because they have different in the antenatal management, but also their intrapartum and postpartum management is different. So we have these Rh negative mothers as a special antenatal care is required to them. Now, the antenatal management starts, as I told you, first we should know the ABO-Rh status of the patient. Once we are thorough with that, then we can have the husband's blood group. If the husband is Rh positive, then the type, whether he is heterozygous or homozygous, may not be practically possible in our scenarios. So, keeping in mind that if keeping in the mind about her previous history will help us to know whether to deal her with as homozygous. If she already has a history of such loss, then we should think the high chance of recurrence. And if not, then we have a 50-50% chance in each pregnancy. Now, when this lady comes, we got the husband blood group done, and when the husband blood group turns out to be negative, we can relax. We can treat her as a normal patient, because as both are negative, their fetus are going to be negative. So no special monitoring is required in this case. But if the husband turns out to be Rh positive, then definitely the maternal antibody detection by ICT to be done in her first visit, repeated to at 26 and 32 weeks. If luckily the ICT remains negative, nothing extra to be done apart from antepartum prophylaxis. Now coming to the antepartum prophylaxis, there are two schools of thought regarding this antenatal prophylaxis. Some says, some RCOG guidelines also says that a single dose of 300 microgram at 32 weeks will be enough, but others say that as we know the pharmacokinetics of NTD, that this NTD immunoglobulins work for at least 6 weeks and they have a half-life of 24 days. So it's better to cover the late second trimester and the third trimester by giving either 160 microgram if it is available for 26 weeks and 32 weeks, because after that it will once the delivery occurs, the postpartum dose of NTD will take care. So this was about the one who remained RH negative, but the management is not over in the antepartum antenatal care. It has to be taken care in interpartum management. What interpartum management should we do? First, neonatologists are always being informed nowadays for each and every pregnancy, so that's not a big deal nowadays. We should avoid giving oxytocin at the delivery of anterior shoulder, because it is said that if we do the active management of the third stage of the labor, the chances of the feto-maternal hemorrhage are more. So in order to reduce this, we should avoid giving this oxytocin after the delivery of anterior shoulder. Manual removal of the placenta nowadays is rarely being done, but if it is required, we should be gentle enough to prevent this excessive hemorrhage. If PPH occurs and this mother needs blood transfusion, she should always be transfused with RH negative blood. Early cord clamping is indicated in case of RH negative mothers, because this will prevent the feto-maternal hemorrhage, and we should always leave a long length of cord, that is around 15 to 20 ml, 20 centimeters, because this will help us for any neonatal procedure if to be done, and few investigations to be advised immediately after birth from the cord blood like ABORH. We should get the RH status of the fetus, the direct Coombs test, hemoglobin, bilirubin, and the peripheral smear. All these are going to help us in managing the neonate. If the fetus turns out to be RH negative, no further intervention is required. And if it is RH positive, usually we give NTD 300 international unit. But as I told, this is a wrong practice, because we should know the amount of feto-maternal hemorrhage which has it is, because sometimes we land up with inadequate dose, and in spite of our awareness that we have given the NTD, the patient becomes sensitized. So in order, so we have few tests which help us to know whether this feto-maternal hemorrhage occurred, to what extent it is there, and to what extent the feto-maternal hemorrhage has occurred. Nowadays, we are lucky enough that few labs are also doing this Clare-Hot Betke test and flow cytometry, and they will let us know the amount of feto-maternal hemorrhage. Based on that, we can quantify the dose of NTD. But in India, we are not lucky enough to get every 50 micrograms vials and various doses. In India, the standard 2 dose, what we routinely see is 150 micrograms and 300 micrograms. So we have to manage the dose accordingly. It's never wrong to over-treat these things rather than under-treating. Like less dose to be avoided. If we give more dose, it's not going to harm anyway. So I was on the test which we can do after the delivery or any procedure like abortion, cesarean, manual removal of placenta, anything. We should do these tests inadequate to quantify the feto-maternal hemorrhage. We have the rosette fetal RBCs. test is like this. When we have this negative rosette, it means no fetal RBCs are there in maternal blood. And if we see this rosette pattern in maternal, in the peripheral smear of the maternal blood, then it means it is positive. But this is not going to tell us about the amount of the feto-maternal hemorrhage. For that, we need to go for this acid elution test, that is the Clare-Hort.
Madam Dr. Sonia, excuse me, madam, please take care of the time also. And because, okay.
Definitely, ma'am.
Very nice. Okay.
Sure. And this is the Clare-Hort-Bethke test, where we should calculate the volume of the feto-maternal hemorrhage so that we can quantify the dose which need to be given postpartumly, and we should cover this feto-maternal hemorrhage. And this is how the acid elution test, because when we make a smear from the maternal blood, these acid will, the adult cells will get hemolyzed and the fetal RBCs will be seen, they are counted, and with this method we can calculate the volume of the feto-maternal hemorrhage. Now, coming to the postpartum, as I told you, what management do we need to do? That, as I told you, we should first do this test to see the feto-maternal hemorrhage. But mind that we should collect this blood at least 45 minutes after the insult. It means it may be delivery, it may be abortion, it may be anything, any intervention which you have done. The blood to be collected always after 45 minutes, because sometimes the fetal RBC may take time to come into the maternal circulation. And once we have quantified the feto-maternal bleed, then we can manage the dose accordingly. Routinely, if in the situations where we think that this test is not possible for us, we can go ahead with the standard protocol of 300 micrograms, and this will cover 99.7% of the patient, and remaining 3%, if we think we can double the dose, this 300 micrograms of this NTD will take care of around 30 ml of the feto-maternal hemorrhage. Routinely in a pregnancy, we expect the feto-maternal hemorrhage not to be more than 2 to 3 ml, and it's already taking care of 30 ml, but still in few situations, we may have this amount more and need to increase the dose. Now, if we are dealing with a previously affected pregnancy where already she is ICT positive, then in that case we need a frequent follow-up, maybe weekly, by MCA Doppler. Now I would like to stress on this that middle cerebral artery peak systolic velocity is one of the most important non-invasive tests which will let us know about the anemia status of the fetus, and we are whole and soul concerned about the fetus when they are developing anemia, and when we need to start the active management, because the active management in the fetus can be offered as early as 16 to 18 weeks, and so the watchful fetal evaluation is required in a female who has already been lost any fetus due to this, and we should be aware that we should start this at least 6 weeks prior to the last mishap. If the patient gives history that my last fetus became intrauterine dead at 32 weeks, we should start the active watchful evaluation by at least 26 weeks. Now, as I told you, the middle cerebral artery peak systolic velocity is the one most non-invasive method to see whether the fetus is developing the anemia or not. It is very simple. We can Doppler study we routinely do, and we routinely see the MCA PI for IUGR, but in this case we have to mainly stress on the peak systolic velocity. You can see the difference in the graph. Routinely we have such type of graph for the middle cerebral artery, but in case of anemia, this is the systolic velocity is definitely increased, and this is because of the thinning of the blood. So when we do this in after 18 week, MCA Doppler is done 2 weekly, and we have these graphs in which we can plot the PSV based on the gestational age. Once this is crossed by 1.5 MOM, it is the time that we need intervention in the form of intrauterine blood transfusion. And if we are lucky enough and to reach up to 35 week with less than 1.5 with 5 MOM, we can deliver them and we can manage them postnatally. Now, coming to this graph again, as I told you, once I'll discuss this, it will be easy for you to understand. Whenever a patient comes to you, first we should know the RH status of the female. Early ultrasound is note how at what gestation age she is. We should know the husband RH status, because if he is RH negative, no intervention is required. If husband is RH positive, then based on the heterozygous or homozygous, we may have both the possibilities. But even if we are not doing this test, we need the indirect Coombs test of the mother. If the mother is ICT negative, means she has not been sensitized yet, then we can manage her by repeating this ICT at 26 weeks. At 26 week, we can give the prophylactic dose of NTD and repeat this ICT along with MCA PSV at 32 week. And if still it is ICT negative, we can give the second dose of prophylaxis for NTD. Now, if by chance she is ICT positive, then we need to see the titer at least. If the titer is less than 1 in 32, 1 in 32 is considered to be a critical level. But please never ever believe on this, because for us ICT positive means ICT positive. Once if somebody is ICT positive, we have to monitor her not only based on these her critical ratio, but also on the MCA PSV. So we will monitor her 2 weekly with the help of MCA PSV, and once we see that the PSV has crossed 1.5 MOM, that is the time we need for fetal transfusion. If we are lucky enough to have this MOMs less than 1.5 MOM to quite a good time, when the fetal hematocrit is good enough, we can deliver, we can drag them up to 33, 34 week, and we can deliver them and we can manage them postnatally. But if we see that hematocrit has fallen down less than 30%, the fetus is anemia. So in order to prevent hydrops fetalis, we'll plan for fetal transfusion accordingly. Now, as I told you, this is the way how we monitor that MCA PSV 1.5 MOM, more or above, we need intrauterine transfusion. If it is less, then we monitor it accordingly and deliver once the lung maturity is good and our neonatologist is comfortable enough with RH negative and prematurity. The management of this depends on the intrauterine transfusion. I'm not going in much details because of time. And this may be carried out between as early as 18 weeks to up to 35 weeks. Usually after 35 weeks, we don't do this because it is a good time when we can deliver the baby, and the baby can be managed in NICU regarding this by giving exchange transfusion and phototherapy. The amount of the blood which has to be transfused in intrauterine blood transfusion can be calculated nowadays with softwares which are available, and also the perinatology.com will give us the amount which can be transfused. Usually it is basically the RH negative packed cells which are used for this intrauterine transfusion. So coming back to my management in antenatally, where is the specific condition where we need to give this NTD is abortions. Please don't underestimate abortions because they may also lead to sensitization. Any invasive procedure which was done in antenatal period, any antepartum hemorrhage, all these things need to be covered by NTD. Once you have given a dose of NTD, it will take care of this for next 6 weeks at least. So now the recent advance one, what we should know is that nowadays we have the cell-free fetal DNA test. Recently, it will be in near future. It will be launched by few of our labs where we'll able to come to know the RH status of the fetus as early as 10 weeks. So we are waiting for this cell-free fetal DNA to know the RH status of the fetus. And we have various tests like point-to care test where we'll come to know the early as the RH status of the fetus. We should also get the 50 microgram dose because as I told you that the amount of fetal-maternal hemorrhage may be quite less in early pregnancy, but it need to be covered with NTD. But we are not yet we are not getting this 50 micrograms in our Indian scenario. As I told you, only 150 and 300 are available. So we have to give at least the minimum dose of 150 to cover the first trimester abortions. Nowadays we have a concept of, the weak NTD. The weak NTD are the one which has the NTD on their, which has this antigens on their RBC, but the amount is less. But they are also the one who can cause the sensitization, and so NTD should always be given in that case. So my take-home message is that every woman coming to your antenatal clinic should have her ABO-RH type in the first contact. Also obtain the ABO-RH status of the husband who are found to be RH negative. We should ensure that ICT to be done in the first visit 26 and 32 weeks with appropriate antenatal prophylaxis be given. A single dose of postpartum, as I told you, sometimes may remain inadequate in case of severe maternal hemorrhage. So the fetal-maternal hemorrhage to be calculated, the amount of blood we should know, and we can titrate the dose of the NTD according to that. Now the common problems which we face is the high cost of immunoglobulins, lack of resources, lack of knowledge, lack of awareness, and sometimes poor turnout to antenatal clinic. Missed cases can also lead to this. So my recommendation will be the adequacy of the partnership, that the government and the NGO should help us in subsidizing these the cost of immunoglobulins, and special insurance to be provided by for RH negative women in order to have their further management. And we should make premarital counseling should also involve this RH status. Creation of the specific groups of RH negative where they can meet a RH negative spouse. So with this, I end my talk. Thank you.
Okay, thank you.
Thank you, ma'am.
Thank you for such an elaborate and very nice. We really remember to do the antenatal ICT at the first visit, and take-home message is definitely the best clinical practice is to give timely antenatal and timely postnatal, and the doses also, so that we can conquer this disease. This allo immunization is not so difficult to manage. We must prevent the secondary and tertiary prevention also, because if we are able to do the best antenatal care, to give the best antenatal care, we will be having less problems of fetal anemia and the jaundice and all those blood transfusion later on. So it's a role of the gynecologist is too much. Thank you.
Most welcome.
Next.
Uh, Dr. Archana, might I request you to kindly introduce the moderator for the panel
Oh
session?
yes, oh yes. It's my proud privilege. It is that today the panel is going to start, and the dynamic moderator is Dr. Karuna Mandal Yadav. She is the director and consultant of maternal fetal medicine, Orchid Women's Hospital and Fetal Medicine Center, Jaipur. She is a pioneer of fetal medicine in Rajasthan, and she has done more than 100 fetal blood transfusion at her Jaipur center. And I hope that with the good antenatal management, there this fetal transfusion will be very less, and over 5,000 invasive procedures like CVS and amniocentesis, amnioinfusion, cordocentesis, fetal blood transfusion, fetal reduction, and thoracentesis, and Fetal Medicine Foundation India certified trainer for fetal medicine. So welcome, ma'am.
Thank you, ma'am. Thank you for the kind introduction. So we are already late.
Yes, we are already late.
So,
So quickly quickly you call your panelist and then start the panel. One is a Dr. Shruti Birla, and she's a fetal medicine consultant, Suryam Diagnostic Center, Jaipur, and already laparoscopic training and from PG Paul Institute in October. I think no need to read all the CV, or yeah, should I?
No, you go fast.
Then only introduction in one line.
Now the next one, Dr. Shruti Birla. Now you are welcome, and Dr. Savita Bansal. Very nice. This kind of CV I really like. Not much to the senior consultant fetal medicine, the big the DM medical genetics and Fortis Escort Hospital, Jaipur. एक्चुअली बड़े लोगों का इंट्रोडक्शन हमेशा छोटा होता है शायद. डॉक्टर रवि दादा, ही इज अ ट्रांसफ्यूजन मेडिसिन from PGI Chandigarh and DNB in immuno hematology. I think he was already introduced by Dr. Leela. And the next one, Dr. Satyen Rajani, and he's a neonatologist. Sir, you are highly welcome. And he's from Gripmare, New Delhi, gold medalist. Yes, and next, Dr. Rashmi Agrawal, fetal medicine consultant and director, Shri Ansh Advanced Fetal Care Center, Jaipur. So whole Jaipur is here. And and Dr. Chandrakant Garg, he is a consultant in fetal medicine at CK Garg's Advanced Fetal Medicine Center. Dr. Leela, आपने सब बहुत highly qualified panel बुलाया है. So Dr.
ऐसा है कि जो राजस्थान में शुरू कर रहे हैं ना, अब राजस्थान भी कुछ हो गया है, ऐसा ना समझो कि हम.
Yes, I'm highly impressed. And Dr. Manu Goyal, she is an MBBS MD, AIMS, Delhi, DNB, FMS, MR, COG, Associate Professor, OB-GYN, AIMS, Jodhpur. My God. Okay. So, full. Dr. Karuna, you have very good panelist. And देखो आप आगे
Thank you
क्या हो
for
रहा है.
introducing my panelists, ma'am. So, we directly
So,
go
are
on.
we all connected? Please confirm.
Yeah, hi.
Are we connected?
Yeah, ma'am.
Okay.
Hello.
Yes.
Yes, we can hear you.
So, now we'll start with our panel discussion right from the first case. First case is 4th gravida, para 1, abortion 1, live 1, ectopic pregnancy 1 with 12 week of pregnancy, A negative blood group for routine antenatal registration. So what will be the clinical approach? Dr. Savita Bansal.
Yes. First of all, we have to be very, very thorough in taking history. That what was, if she has a live baby, was it a term pregnancy? What was the sequence of pregnancy? Was the first one was abortion, ectopic, or first one was live? Because all these things are important. If she has an abortion, she took a medical abortion, or whether the abortion was around 12 weeks, whether she took NTD or not, whether she was aware or not, whether she knew her blood group before doing her abortion or not, and was the ectopic pregnancy managed medically or surgically, whether NTD was given or not, whether blood transfusions were given or not, and whether the blood transfusions were RH negative or not. So all these things are very, very important before jumping to what we are going to do in this pregnancy. Partly, Sonia Meal has also covered all these issues. Like if a first pregnancy was an abortion, whether it was a surgical abortion or not, whether she knew her blood group beforehand. For example, it is very common in our scenario that people go as OPD consultation, get an MTP done and come back. Nobody knows the blood group and nobody is bothered. And abortions, especially surgical abortions, they should not be taken very casually because some subchorionic bleed and hemorrhages, they are more common in surgical abortions, and ideally NTD prophylaxis of 50 micrograms should be given. In medical abortions, if they are done at because they are done at less than 7 weeks, if sometimes some people don't give opinion of giving an NTD, it's fine because chances of sensitization in medical abortions, especially and when abortions are less than 10 weeks, they are very, very low. And then is a few words about ectopic pregnancy. We know that if it is a ruptured ectopic, there is a lot of blood into the peritoneum. But we must understand that it is not fetal blood, it is maternal blood. And the dose of NTD or chances of fetal maternal hemorrhages are not really high in ruptured ectopic pregnancies. And now we'll come to this pregnancy, which is 12 weeks. On first booking, we have to do her husband's blood group if it is not known. If husband's blood group is negative, then the whole story is over. And if husband's blood group is positive, then genotyping of heterozygous or homozygous is of no practical significance because even if the risk is 50%, it is very, very high. But nowadays, a new addition of cell-free DNA is a very good step. If family is not, there is no issue of affording and family is very anxious about Rh negativity, then yes, we can go ahead with cell-free DNA for finding the Rh status of the fetus. And if Rh status of the fetus is positive, then this pregnancy should be followed by ICT. And like cell-free DNA in this low risk, I think is not suitable. We can avoid this. But once the pregnancy is first booking, we will do a ICT, indirect Coombs test, which will classify the pregnancy as Rh sensitized or non-Rh sensitized. If it is negative, then we have to do 2 more testings at 24 weeks and 28 weeks. We at Fortis Hospital, we follow the protocol of giving 1 NTD prophylaxis in Rh negative non-sensitized pregnancy. So we do at 24 and 28 weeks indirect Coombs test. And if both the tests are negative, then we give an NTD prophylaxis in the deltoid. Specifically, we give 300 micrograms dose of NTD, and then we explain the patient that further ICT is not needed because the NTD will cover the small amount of fetal-maternal hemorrhages. But if this pregnancy, there is any chances of high fetal-maternal hemorrhage during this whole pregnancy in the form of threatened, in the form of bleeding or abrupt show, then we might repeat a NTD if it is less than 6 weeks before, or if possible, we can look for amount of fetal-maternal hemorrhage by doing a Claire-Bacter test. So I'm saying Claire-Bacter, but I think I don't know who is doing in Jaipur. So it will be an addition if Dr. Karuna tells me where should I go for Claire-Bacter test.
1 or 2 clarifications, madam, I would like. One or two clarifications. First thing, I would request all of you to be very practical and clinical. I want this panel to be totally clinically oriented. How many of us, first thing, can afford cell-free DNA for RH? Second thing, do you mean to say that for ectopic pregnancy and medication termination, we do not need to give NTD?
No, I'm not saying that we do not need to give NTD. For ectopics, we need to give NTD, whatever the dose we recommend for first trimester medical abortion. We do not need to give a very high dose because there is lot of bleeding in the peritoneum. And for medical abortions, there are many trials and observations. They say that the chances of fetal-maternal hemorrhages are very, very less. And theoretically, we cannot say that NTD is not needed. But if somebody
is overdosage of NTD better or underdosing?
Yeah.
Is overdosing of NTD better or underdosing?
Underdosing is not better, but if we are giving overdose, then it is better to look for fetal-maternal hemorrhages by doing Clarebacter test and
That
all.
will come in the next question,
Okay.
with the availability and practicality. So what will be the, I mean, you have already discussed in detail. And the other question is, should anti-D be given to isoimmunized mothers? Because this is a scenario which we come across as a routine. Mother is RH isoimmunized. Should we give anti-D injections or not to them?
Like we are doing in all antenatal pregnancies, most of us know that ICT has to be done. ICT is indirect Coombs test, and once it is positive, what is the meaning? Like sometimes we have observed that an anti-D has been given, injection of anti-D has been given at 28 weeks, and then if ICT or antibody titers are done, they are positive in lower levels, because anti-D injection itself gives you a report of anti-D titers positive in a lower level, like it will be 1:2
Yes,
or
yes.
1:4 positive, and we can easily tell the patient that it is because of the injection which has
That's true.
been given.
Herein, this is what I wanted the clarification. That
Right?
if the mother is is isoimmunized, then we do not need anti-D injections. Once ICT is
I'm
positive, we do
coming to
not
it.
need.
I'm coming to it, because one common scenario is this also, that at 28 weeks somebody has given anti-D and then the ICT has been done. So if ICT is positive in lower dilution, it doesn't mean that patient is sensitized, because anti-D injection itself, they give low titers of antibodies, which you can see up to 6 or sometimes up to 12 weeks.
But
And if
excuse me,
mother
madam. What I want to know is, suppose ICT is negative at 24 weeks and 28 weeks, the ICT is negative, then you vaccinate. I mean, you give the anti-D, and after that, you don't. Do you repeat ICTs after that also?
No, it should
No,
not
no.
be done, because it will give you a false report.
Positive.
Yeah, it
Of
is not
positive
needed. And the
that's in
sensitized means ki she is positive. As I suppose at 20 weeks you did the test ICT, it came out to be positive, and positive means around 1:8.
1:32 is the critical level which we all practice. But if
Madam,
women-
32 is too much critical. But
No, herein I would like to intervene, madam.
yes, madam, Karuna.
Herein I would like to intervene, because we have disparity with the labs. One is going to give you anti-D negative report, the ICT negative report, the other will give you positive. So there's a lot of disparity. So herein what I would suggest is, the gold standard is your ultrasound, MCPSV. And whenever positive, then you have to be cautious. Dr. Dara, would you like to add anything?
Yeah, see, many times you get like ICT is positive from one lab, ICT is negative from another lab. I want to clarify here. I am audible?
Yes, you're
yes,
audible.
audible, Ravi, audible.
Yeah, ma'am. Ma'am, I want to just give you a clarity between what is ICT and what is antibody screening. See, in ICT, what we are finding out is where there is any anti-D or any antibody, it's not only anti-D, any antibody which is present in the female, in the patient's serum, and it can harm the baby by crossing the placenta. This is called as a ICT positivity. We are not looking for any specifically anti-D, we are looking for all antibodies in this. But in ICT, what we do, we used to direct them against the O blood group of red cells. O positive red cells. It's a pooled O cells. We get it from donor, and we treat them with the patient serum. We incubate them. We check it with the AHG methodist Coombs sera, and if it is positive, it means that there is an antibody. There is some antibody is there which is directing against that antigen present on the red cells. Okay, but what about antibody screen? In antibody screen, I can show you my screens. Just a minute. Okay, I can't share my screen. Is it possible?
Session, can you help us?
Is it possible?
Karuna, you have to stop your screen, then only he can put his screen.
Okay.
Oh, thank you.
Now you can share, Ravi.
See, this is the one. This is the antibody screening panel. It is. This is not only a single cell. You can see here there's 3 cells: cell 1, cell 2, cell 3. These are 2 O positive cells with different type of antigens on this. Okay, this is O negative cell with different type of antigen on cells. This is the difference we do. If do antibody screening, you will get a proper picture and antibody screening is positive. This is the reason many times you get an ICT negative, but antibody screening is positive. See, antibody screening is much sensitive than plain ICT. I advise you to go for antibody screening instead of doing ICT nowadays.
Another important thing I would like to mention here is the anti-D what we're giving is monoclonal. So we are talking only about anti-D. But if in the antibody screen you find the other antigens present, then you are more sure that it is because of the ISO immunization, because many times the patient will not even know whether they have taken anti-D injections or not. So this is the role of antibody screening. Can you stop sharing, Ravi?
Yeah, ma'am, just a minute. Yeah, it is.
Plus, can I add a few words, Karuna?
Yes, ma'am, please.
Because like you asked me whether should we give anti-D once the patient is RH sensitized, then the answer is no, because patient is already having lot of antibodies already built up, and there is no use of giving an anti-D. It will be like समुद्र में एक बूंद पानी डाल के क्या होगा, तो वो नहीं देना है, उसका कोई यूज नहीं है. बल्कि once the patient is RH sensitized, she will be RH sensitized throughout her life. And only the antibody titers can sometimes become low or high. And if there is a history of a poor fetal outcome, then antibody titers alone should not be the method of monitoring, should not be the...
So we come to a conclusion that the gold standard is the ultrasound MCA-PSV.
Yeah, that one is coming.
The next question, Manu.
There is a history of a fetal loss. For example, an intrauterine death has occurred, that we must believe that it was hydros fetalis unless not proved. If she's an RH negative pregnancy, there is an intrauterine death, then we must say that it is an hydros fetalis unless not proved. And if it is a fetal loss, that means it is a sensitized pregnancy. If it is ICT is positive, RH antibody titers are above the critical level. And when she becomes again pregnant, then the pregnancy should not be monitored only on the basis of antibody titers. We must start doing ultrasounds, like Karuna has rightly said, in the form of MCA-PSV, preferably 2 weekly. And later on, when she reaches the critical level, like history of previous infection or...
No, madam, it is very much sure that we have to monitor the patient, not the testing. So that...
the blood serology is of no use once there is a history of intrauterine death.
Thank you. So the next question goes to Dr. Manu. The next question patient will ask is, how many transfusion will be required and from when? Do you give guarantee of the baby? So how do you manage this question of the patient?
So Dr. Karuna, thank you. Basically, we will start transfusions when we do the serial ultrasound. Now, Dr. Savita has mentioned briefly that how do we go about the history and testing. And now we got to know that patient is isoimmunized. And now we have to follow her up with the ultrasound for MCA-PSV, Doppler, and other features of fetal height drops. And if there are features of height drops like centromegaly, polyhydramnios, or any effusions in the cavity, or MCA-PSV is going beyond the critical titers, like it is going beyond 1.5 mmol, we start doing the titers MCA-PSV from 16 to 18 weeks of gestation, and then we plan the intrauterine transfusion. And we can do because the numbers are not fixed from the gestation. It is basically dependent how early we need to start transfusion and how is the outcome after per procedure. Like if we have transfused a good amount of adequate amount of blood in a single sitting, and then the post transfusion hematocrit is almost reaching up to the required level, that is 40 to 45% of the fetal blood, then we can plan the next transfusion after doing the chordocentesis or following with the MCA-PSV. But
so
if
so
the patient, and we can never guarantee the baby outcome of the baby. We can never say that we will be able to save the baby because anytime if the patient is having history of previous height drops, then definitely there is high chances of recurrence, and it is the guarded prognosis for the fetus. But if we are going regular transfusions, then we can deliver, we can give guarded prognosis to the mother that yes, they can have a live baby afterwards.
Thank you. The message is very clear. that we start transfusing once the MCA PSV is more than 1.5 ml, and it is not a 100% success rate. So thank you so much. So next question is, what are the maternal complications? Again to Dr. Manu.
Okay, so we have certain maternal complications. The procedure related, some are the procedure related complications, and some are inherent complications which are related to the fetal status or previous maternal history. Complications might include sudden fetal distress and emergency
Maternal
cesarean
complications.
section,
Maternal
and
complications.
infections, and premature rupture of membranes, and preterm deliveries, and definitely maternal distress because of this thing, the fetal loss or fetal uncertainty of the
So
fetal outcome.
mainly the complications are related to the fetus and pregnancy loss. Generally, the mother is safe, other than the coronaritis and the infection.
And
So, do all the babies need NICU admission irrespective of blood transfusion, intrauterine, or this goes to Dr. Satin. Dr. Satin, am I audible?
Yes.
Yeah. So, do all babies need NICU admission to all RH negative mothers? What is your opinion?
So, Dr. Karuna, this will be a very short and sweet that all babies do not need NICU admission. We have to see what is the antenatal part, what is happening with the, you guys tell us actually what is happening with the MCA, PSV. So, risk categorization happens over there. Secondly, the history, bad obstetric history, prematurity, hydrops, any features of hydrops, all these guide us whether this baby needs into the NICU or not. And thirdly, the baby's cord bilirubin as well as the cord hematocrit values will guide us whether this baby can stay safely with the mother or should be into the NICU.
How
And obviously,
reliable
if
is
it
the
is
cord hematocrit and bilirubin after blood transfusions?
so after blood transfusions, probably no. This will be guided only in case intrauterine transfusions have not happened.
Thank you so much. So now this lady has a history of anti-D injections post-delivery, but she is ICD positive. So this already Dr. Ravi has answered the disparity why this happens in different labs. So what are the possible causes of RH immunization, Dr. Rashmi?
Yes, ma'am. The possible causes of isoimmunization, first of all, may be the inadequate dose of the anti-D which we have given at the time of delivery. If we suspect the more maternal hemorrhage, then we calculate the dose accordingly. The second cause may be we are giving it at the incorrect site. In some centers, NTD is administered at the intergluteal region, which may lead to the delayed absorption of the NTD. Third reason may be the improper maintenance of the cold chain, which can lead to the agglutination of the NTD. And fourth cause may be the patient has not received NTD after the initial antepartum, first trimester miscarriage or the ectopic pregnancy.
Good, thank you. So what is the dose of anti-D to be given after delivery, miscarriage, ectopic pregnancy? Should we give anti-D to all the babies born to RH negative mothers with fathers RH positive? Dr. Shruti?
Thank you, Karuna ma'am. To be very short, like after normal delivery, we give a standard dose of 300 mcg in routine, and also after cesarean. After instrumental delivery as well, we usually go for 300 mcg. Theoretically, given KB test, we have talked a lot about, but we don't in practice we don't go for it in routine. And in miscarriages in first trimester, the standard dose is 50 mcg. We can definitely opt for 100 mcg because again, as you said, over treating is never bad. Under treating is the thing which will cause harm. Second trimester onwards, the dose will always be a 300 mcg dose, and in ectopic pregnancy also a 50 mcg dose to a 100 mcg dose we can decide over it. And no, not every RH negative mother is to be given NTD if a father is RH positive. If it's a normal delivery, we have definitely we have to go for the blood group of the baby, and then we can decide over, because we still have a good time of 72 hours, and a blood group does not take that long time, so we can decide over it.
Thank you.
Over to you, ma'am.
So,
Thank you, ma'am.
can the blood group of baby change from negative RH to positive, and how late, Dr. Dara? Dr. Ravi, can you hear me?
Yeah, the question is, can a blood group of baby change from negative RH to positive?
Yeah, first we tested it was negative and then it becomes positive. Is it
Ma'am,
I
it is
think
not.
it is after the intrauterine transfusion.
after the intrauterine transfusion and without the intrauterine transfusions also?
Okay. In both cases, na?
Both cases.
Ma'am, first of all, I want to say when we're labeling as a baby as a negative, you should not directly label as negative. You should go for a week D testing.
Yes.
Week D testing is most important in this. Never label directly baby as a negative. You should ask for what is the week D status of that baby. If the week D status is positive, then the baby should be considered as positive only. See, there are multiple cases, like your cases, 2 cases was there with us. There was a block D phenomena is there. Very short time I am not, otherwise I will explain you what is block D phenomena. There, here the D is blocked. It looks like it is negative, but it is not negative, it is positive. Baby is positive actually.
Thank you. Thank you. This is what I wanted to know. So, in cases wherein you are in the your lab cannot give week D status, then spending 2,500 rupees is easier. So, what is the preferred site? Rashmi, we've already answered. So, is there a difference in dosage between a vaginal and cesarean delivery? Dr. Chandrakant, this is for you.
Yeah, there is a difference. There is a no difference between the vaginal and cesarean delivery. But in case of a maternal hemorrhage or in case of the PPH, we can quantify. We can quantify the feto-maternal
APH,
hemorrhage
APH,
by
yeah.
KB test, and then we can increase the dose according to the requirement.
Very good. Thank you. How do you decide the dosage? Dr. Ravidara, what are the tests available to decide?
In ideal situation, it should be by KB, but unfortunately, it's not available. I think so. But as you all are interested, I can give you in a month. I can start it here.
Thank you. We'll be looking forward to it. Thank you.
And so one thing, ma'am, one thing I want to clarify here.
Ravi, can we start doing it for all RH negatives if you permit? You keep the dose cost low. Then we will start doing it for all RH negative pregnancies after delivery.
Then I will keep my lowest cost possible.
And you will be available whenever we need you.
Yeah, yes, he's always available.
He's always available, ma'am.
Chalo, thank you so much. We'll change our practice.
Yeah. So we've already discussed the causes of RS isoimmunization. Easy availability of MTP pills also is a main culprit. Then poor maintenance of cold chain. That again I wanted to point out. So now, any further investigations do we require once ICT positive, Dr. Manu?
Yes, once ICT is positive, like Dr. Ravi has said, that we should have full antibody screening. Okay, and it is not just the only thing to be done. And second thing, definitely, I would like to know the titers of ICT test which have been done. And variable labs have the varied titers, like 1:16. Some take it as critical titer, 1:32. But if it is positive, then and previous bad obstetric history, then we should go about with.
Even if it's herein, I would like to emphasize, even if it's not a bad obstetric history, it is all pregnancies are precious. And positive means positive for us. So we need to monitor it by USG MCAPSG, which is a very good sensitivity. So what are the benefits of antibody typing? Dr. Garg, partially it has been answered, but please throw light on it.
Yeah, it's already answered, ma'am, but it is better to do a complete antibody typing. So we came to know which antigen is responsible for the ICT positive. First thing, other than anti-D, it is like E and Kales and Duffy that can also cause ICT positive, and so we came to know about the antigen.
Any role in the postpartum period? After delivery, is it going to help us some way? Dr. Satyen, would you like to add?
Sorry?
Postpartum, the antigen typing, is it going to help us?
Yeah, so I think, antibody typing, as you've illustrated, would help us in determine when we are performing an exchange transfusion to perform the cross match appropriately. That is very, very important.
Thank you so much. Because many labs will tell you, ma'am, the titer is so high that we are not able to cross match, but actually titers are nothing to do with the cross match. It is the different antigens which the labs are not testing. So herein antibody typing is very, very important. Once it is ICT positive, you need what all antigens present, what all antibodies are present.
Karuna, just I want to know,
Yes, ma'am.
if the labs are saying that we are not able to this cross match the blood
Yes,
because
ma'am.
typing is not available everywhere, then what to do? Because the consultant is at the confusion.
Ma'am,
Ma'am, I
Dr.
am
Ravi
here.
is there with us.
Ma'am, I am here. Send it to me. I will get you all the blood.
Ma'am, within an hour he gives the results.
Ma'am, I am here. Nothing,
Ma'am,
not to
actually
worry
the
about.
problem is that especially these kind of, we have to know that when along with anti-D, if there are other minor antigens also present, then these, the outcomes are very, very bad. The other thing is if not properly matched, it's like partially the titers of others are low, then in that case the frequency of our blood transfusions are going to be high. So actually it is very, very important.
Can
Unfortunately,
we
not
add
many
few
of us.
lines here? Can we add few lines about whether there is any role of IVIG in RH negative
We
pregnancy
will
or
come to
not?
it, ma'am. We will come to it. We
it.
will come to
Is
it.
there in your presentation?
Yes, ma'am. We will come to it.
Okay, okay. I want to hear.
So, how do we monitor these patients? Antibody titer or MCPSV? This actually we have discussed that once positive, then instead of spending much on the titers because they are not much reliable, we prefer performing ultrasound by MCA-PSV, and that is more reliable and more practical. So MCA PSV has been reported less than 1.5 mmol repeatedly, and suddenly the fetus is found to develop ascites and pleural effusion after 2 weeks. So what could be the cause, Rashmi? Dr. Rashmi Agarwal.
As we all know, in Doppler studies, all the velocities are angle dependent. So during the measurement of MCA PSV, the angle of insonation between the ultrasound beam and the blood flow should be close to the zero. It might be possible that the radiologist or the sonologist who is measuring the MCA PSV have not corrected the angle. So we should take the MCA measurement by taking all the precautions, and if it is more than 1.5 mol with features of hydrox, then we should go for the intrauterine blood transfusion. And
Is post MCV and post imaging angle correction as accurate as pre measurement?
sorry, ma'am.
Post processing angle correction after the image has been taken, is it as accurate as the angle of insonation being zero?
No, ma'am, it is not as accurate as that. But in due to the fetal position, sometimes might not be able to get that insonation angle. So the angle correction post taken is good enough.
Still, we are dealing with precious pregnancy, so I would advocate better to have patience and make the angle correction zero pre-imaging. So this is the way we take it. Thank you so much, Rashmi. How do you monitor? Like how frequent do you call them? Rashmi, how frequent do you call them?
Ma'am, every 2 weeks for MCA PSV, if the ICT titer is below the critical threshold level, and if it is more than 1:32, we will follow every week.
Herein, I would like to emphasize once, there's a chart available wherein it makes you put the patient in the zones as shown here on the screen. If it is in zones D, you can wait till 2 to 3 weeks. If it is in C, 7 to 10 days. B, repeat within 5 to 7 days. And even if you can wait for 3 days before the transfusions, it is better to wait rather than early transfusion. So this is the way. And what is the so next is what are the common causes of false positivity of MCA PSV and how will you overcome that, Dr. Manu?
So, false positivity can be due to advanced gestation after 35 weeks, first of all. But other causes, while we are doing between 20 to 35 weeks of gestation, it could be because of the more pressure on the probe while we are doing the this thing MCA-PSV, and sometimes fetal body movements and fetal breathing, which is usually the hindrance in advanced gestation. So. And definitely this should not be, and the site where we are taking the MCA-PSV, like it should be just in the soon after the origin. Some people take it at the origin, so it could be false positivity.
Around middle one third. Around
yes,
middle
yes,
one third. Yes.
in the middle one.
So probe pressure should not be much. And how will you overcome that?
So it should be, we can ask the patient to just fill the bladder and partially fill the bladder, and then we should not press, and the angle should be definitely it should be the zero angle of insunation, and it should not be applied pressure. Only we should do it by color Doppler, not by putting the more pressure on the probe.
Yeah, that's true. So we should not put a lot of pressure. The other thing is you have a look at the vessel caliber. If there is hypoxia, the vessel caliber will be more. And the third thing is looking at the LV function. So the squeeze and echo is very, very important. So those things also you have to take in account. Isolated MCA-PSV has 88% sensitivity and has around 10% false positivity also. So in total, you have to see everything. You have to see the placenta texture, the thickness, and overall, if the whole look of the baby in total looks hydropic. So these things you're going to take care, which will help you in reducing. After some time, if you repeat the thing, then again, possibly your MCPS will be fine. So you can do
just one line to add, madam, and the gate of, like you have mentioned, this vessel caliber, that gate of this measurement should also be adjusted according to the vessel caliber.
Exactly. Thank you. So now we come to the second case. You are sitting in a peripheral center with a 39-year female coming with gravida 9, para 8, 0 abortion, live 1. First child was a neonatal death at 3 days of admission in NICU. The cause was not known. Second baby had history of NICU admission, cerebral palsy. Last delivery was full-term IUFD around 36 week. 37 week. It was a full term. Now this time it is presenting with severe ascites, pleural effusion, generalized anasarca, cardiomegaly, pericardial effusion at 34 weeks. So how will you counsel, Dr. Shruti?
Ma'am, here the blood group of the patient has not been mentioned. So obviously, looking at this, yeah. So at this stage, I will definitely need to go for an NCA PSV. Hydrops has already been developed. Her referral at a tertiary center is being me at a peripheral center in this case. Her referral at a tertiary care center is very essential. So most important thing that I have to counsel the baby is about the prognosis of the fetus if I deliver the fetus at any stage at a peripheral center, because post delivery the baby will in many cases need an NICU admission. It may develop neurological problems. It may end up as an IUD, or looking to all these things, it is very essential that the transfer at 34 weeks should happen in utero only. So my preference would definitely be, and my counseling will be oriented for an in utero transfer at tertiary center.
Okay. So now the patient is shifted to tertiary center, Dr. C.K. Garg. Other than the RH workup, which we have already discussed, how will you proceed?
So this baby is already developed hydrops, and so we should see for the infections. We should screen for the fetal infection, parvovirus especially, and we should look for the detailed ultrasound examination of the baby organs, and we need to see a placenta, and we need to see about the heart, or fetal echo is also the essential part. So we can see in that placental thickness or polyhydramnios, maybe there is a myocardial or bowel dilatation also we can see there. So these are the things we need to see.
Correct. So that means in total you're going to examine the baby as a whole, because the patient is coming from periphery. She might not have had a very good anomaly scan. So before anything, any interventions and so much cost involved in everything, we need to examine the baby in toto, and we need a recounseling. That it's not like many a times people when there are isoimmunized, they say that now to Bhagwani Malik hai, so those things are not to be done. We can save these babies also. So that those counseling, positive counseling also has to be done. Along with that, we have to tell them the guarded prognosis and echo, and as you said rightly, that all organs need to be examined. So what should be the timing of delivery, and what would you prefer, intrauterine transfusion or exchange transfusion post delivery, Dr. Satyen?
So, Dr. Karuna, I think the timing of delivery would be depending on where the baby is. So if it's now in a
she shifted to tertiary center. She has come to you.
Okay, so tertiary care center, I'll be happy if the baby is close to term. So 37 weeks and above would be very, very happy. But if in any case the baby is getting compromised and other things cannot be done in the antenatal part, then 35 weeks is a good enough target. Um, but the role of intrauterine transfusion or exchange transfusion, so obviously there are practical limitations in arranging for an exchange transfusion. Specifically, even in a tertiary care center where we do not have immunohematologists all across, just one in the Jaipur. So there are to be, cross matches and all these things need to be arranged, and that is possible only after the baby is born. So I think, this does require almost 4 hours after the baby is born, wherein we know that after the baby is born, the bilirubin levels may start rising within minutes to hours. So it will be much more preferable if the baby is born in a much more hemodynamics better state with the IUT performed before the baby is delivered, if that is possible.
Thank you so much. So the message is very clear. A compromised preterm baby, it's better to give intrauterine transfusion, let the baby, mother system work, other systems, and correct the fetal anemia so that the cardiac hypoxia and also is a little compensated. And then we can help. And thank you for the confidence, Dr. Satyan, to save our babies. So, what are the important factors affecting the neonatal survival? How safe is the exchange transfusion, and what are the neonatal complications, Dr. Satyan?
So exchange transfusions are, one of the most critical procedures that we perform in our NICU. And it is almost like we set it up almost like an operation theater while we are performing an exchange transfusion. So it has a mortality which was associated in the classical times of just 0.3%. But nowadays, since it is being performed much more rarely, but for more critical cases, it has been reported that mortality is somewhere around 8% to 5% as well. And this will depend basically on how the baby is, what is the prematurity and all, and what are the other complicating factors. So, asphyxia, hypoxia, respiratory distress, sepsis, all these are going to be the cause for further complications in this. Not only mortality, we also have to be aware that this also is associated with acute complications. There could be bradycardia, there could be hypocalcemia, hyperkalemia if the blood is old, acidosis may happen, thrombocytopenia, which is a very common entity. Almost 60% babies have been noticed to have thrombocytopenia after that. So all these complications happen much more. And similarly, even late complications, we cannot be. The late complications could be that this baby may have a late anemia, which may require further transfusions, which could be a hypogenerative anemia, or it could be, neutropenia also that may develop. And sometimes problems of jaundice, like inspissated bile syndrome, which may last for months. So the baby may appear jaundice, and we don't have any specific reasons for that, as well as problems later on in life, which is portal venous hypertension and portal venous thrombosis may happen, which may further compromise the quality of life that this baby may have. So neonatal survival, basically it will be gestation. And even here, I would like to emphasize that although we do care about extremely preterm babies, but even the moderate preterms, 30 to 35, 34 weekers, they have, if they are performed an exchange transfusion, they are almost 5 times at a higher risk of developing death because of exchange transfusion and other complications.
Thank you, sir. So it's the message is very clear that as far as possible, let the mother system work for all other organ systems and correct the anemia intrauterine. Let the baby be compensated before we take it out, because a common scenario is the gynecologist, they counsel that, okay, fine, you are ICT positive, we will conduct a preterm cesarean. So this is not complication free. IUT even at the late early third trimester also is beneficial, more beneficial.
One thing more, if I may add, is it will also depend on when the baby has come. So if in this case, obviously the delivery is happening in a tertiary care center, but exchange transfusion requires, procedural skills as well. So So if the baby is coming late and the cord has already dried, then it becomes more difficult for us to perform an exchange transfusion, first of all. And then the bilirubin levels are much higher, wherein even performing an exchange transfusion might not reverse the neurotoxicity that has happened. So this is very important to counsel to the parents also, wherever whosoever is sending, that it's not the sure shot answer. And even despite exchange transfusion, the babies may have cerebral palsy.
So, having decided that IUT is the safer option, what are the minimal pre-procedure investigations required, Dr. Shruti, for the blood transfusion?
The baseline for me would be first of all a good animal scan, because I cannot get sued by intrauterine transfusing a baby which is animal. So definitely a good animal scan is a must for me, with gestational age, a proper dating, good AFI, placental morphology. I need to know to understand where I have to insert my needle, and I have to see for the whole biometry thing. Fetal hematocrit, obviously with pre-transfusion I'll be doing to calculate how much volume I have to transfuse, and the blood which I have to transfuse, it is to be tested for the blood group, either matching fetus or O negative blood group. Usually we use CMV negative. It should be leukocyte depleted, and the hematocrit of the donor blood should also be tested. It should have a hematocrit of 80 to 90% preferably. So the viral markers are needed to be done, and as you have mentioned on the screen, the CBC is but obvious a minimal thing we need to do, so that we can know the hematocrits as well. So these are at least, and most importantly, baseline is animal scan should always be noted.
Why do we need to check with the CBC?
Important thing is, ma'am, we have to know the hematocrit, the calculation which we do
Maternal
with
CBC. Maternal CBC and viral markers. They are also very important because herein many things. Many times we forget the procedure, the minor pre-op investigations. So therein, she has to, the viral markers of the patient also, mother also needs to be done. And CBC, if the count is high because of other reasons, then that gives you another inverted commas for the guarded prognosis, and you have to tell the patient. So there can be infection to the mother. Those things also have to be taken care of. Thank you so much. So what kind of blood will you request, Dr. Manu?
Okay, so it is definitely the O negative. It is O negative blood, and which should have a hematocrit of 75 to 85%, and it is double centrifuged and irradiated blood, which is plasma depleted, and plus the CMV should be negative, and all the viral markers should also be negative for the blood. And it should be fresh blood. It should not be older than 70 to 120 hours, and so that is the minimal requirement for basically.
Yeah, especially herein, if the baby is hydropic, then as in the adults, higher hematocrit is going to help us and prevent any further cardiac overload. So, how do you differentiate the blood for fetal transfusion from the adult transfusion, Dr. Dara? Dr. Ravi? Am I audible, Dr. Ravi?
Yeah, ma'am. Your question is what type of blood you want for the IUT, ma'am? I think so.
Yes.
Yeah, ma'am?
Yes.
Yeah, I think so. One investigation is missing in this. I will do first antibody identification. Which type of antibodies I am dealing with. Accordingly, I will give O negative. Okay, I prefer O negative, but antigen negative blood. O negative with other antigens also. For example, if the patient is having anti-D, anti-Kel, I have to give D negative and Kel negative also. Otherwise, there is no sense of giving that O negative blood only without typing for Kel antigen. And of course, it is a fresh blood. We have preferably less than 72 hours. But if it is not available, I prefer up to 5 days. It's good enough not to worry for that. And it should be leukocyte depleted. It should be NAT tested in this era. Today's era, it should be NAT tested. Okay, not only ELISA based or chemiluminescence based testing. And one thing more important is it should not have any additive solution. See, we commonly use additive solutions in our blood bags for adult transfusions, but for neonates and for the IUTs, we should not use for additive. We have to remove these additive solutions from there. Commonly the sagum, and it has having a mannitol in this. The mannitol is harmful for the baby, maybe harmful for the baby, so it should not be there. Frankly, theoretically, it should be CMV negative and sickle cell negative, but it is not possible in India. Nobody gives you CMV negative, and nobody screen for sickle cell in blood banks. It is just written. Even I don't write on that thing. and it should be irradiated. The most important is irradiated to prevent the GVHD, the transfusion associated graft versus host disease. And it should be AHG cross-match compatible blood. If it is screened properly and antigen negative, it will always become compatible only. If it is already antigen negative, the cross-match will be compatible always.
Any option if you do not have O negative blood?
Ma'am, we can go ahead if we know the blood groups of mother and father, then it will be an option. We can give a match wise. It is possible, no problem. But it is very difficult, no doubt.
Thank you. Thank you. With so much of care, if the blood is prepared, the frequency of blood transfusion also will go low. Recently, we had a case wherein the baby came with severe hydrops, and it's been 4 weeks we haven't retransfused. Thank you so much. So, what are the routes of blood transfusion, and which is the preferred one, and why, Dr. Rashmi?
Ma'am, can you increase your voice?
Hello.
Yeah, can you hear me now?
Yes, ma'am.
What are the routes of blood transfusion, and which is the preferred one? Why?
There are two routes of intrauterine blood transfusion. One is intraperitoneal and another is intravascular blood transfusion. Nowadays, we prefer to do it by intravascular IUTs. As in intravascular IUTs, we can determine the fetal hematocrit. It leads to the early correction of the fetal anemia, reversal of the fetal hydropic signs, and it is the only option available in the hydropic fetus. Because in hydropic fetus, if we go for the intraperitoneal transfusion, it may lead to the impaired absorption of fetal RBCs through the lymphatic channel.
True. What in cases of less than 18 weeks?
Ma'am, we cannot do transfusion before the 18 weeks because there will be the fetal reticuloendothelial system is immature to causing destruction of the fetal RBCs. So there will be no sign of fetal hydrops before 17, 18 weeks.
And what about the MCA-PSV? So we don't do any blood transfusion before 18 weeks, you mean to say?
Yes, ma'am. Before 17 to 18 weeks, we should not do any blood transfusion.
What if the baby has if the baby develops severe anemia? Though it may not be hydropic, but the baby can be severe anemia.
Ma'am, how we are going to assess it? We cannot.
MCA-PSV?
No, ma'am. MCA-PSV is we cannot take it before 17 weeks.
We have the option of IVIG till then.
Ma'am, we are coming to that. We have a separate question for that. We are coming to that. Intraperitoneal also has a role when the vessel caliber is not adequate and when there are severely high, though these cases are very rare, but then when you have intrauterine deaths very early, there can be other causes. Ruling out if it is RH isomerization, then intraperitoneal also has a role. It's not totally outdated. Another thing was historical interest. Fetoscopic approach was used earlier, but then the complications of fetoscopy itself and the present advancement of the very good high resolution machine. So we're not doing fetoscopic approach now. So what are the different sites for blood transfusion and what are the benefits of each? To Dr. Manu. Dr. Manu, am I audible? Dr. Manu, go ahead.
So we can have hello. Yes, ma'am. Am I audible?
Yeah. Please.
Hello.
Please.
Hello.
Please go ahead.
Okay. Yes, we can transfuse it in the free loop or in the placental insertion, or we can if both these are not available and fetus is hydropic and we need to, sometimes I haven't tried it myself, but intrahepatic portion of the umbilical vein people also have tried it, and some people also have done intracardiac, but most commonly used are free loop and placental insertion of the cord. So these are the two most common sites for blood transfusion, and the benefit definitely free loop has this problem that we can puncture the artery sometimes, and that can lead to spasm and sudden bleeding or cord hematoma. So umbilical vein is the preferred channel to be transfused, and placental insertion we can get the access easily, and plus we can also fix our this thing. There is less chances of slippage of the cord near the placental insertion. So this is the basically benefit for placental site insertion.
So definitely the preferred is the placental insertion as far as possible. Pre-loop, if you have something to support at the back, it might be a fetal head or maybe some of the limb, if you can puncture, but it is really difficult to puncture the free loop. And hepatic vein, definitely it's a little difficult access, needs expertise, but then that is also in babies with fetal anemia, you will have dilated portal vein and it's not that tough. Obese mothers, posterior low placenta, these are easier. Cardiac, when there is no other option out, that is the last resort. I have done 2 and luckily the babies were good. So what are the challenges in fetal intravascular blood transfusion, Dr. C.K. Garg?
Madam Dr. Karuna, please take care. Only 5 minutes are left
Okay, ma'am.
because
So
we have to give time.
Panelists,
already
please help me
discussed
with answering faster.
the challenges already discussed in previous. Yeah. Already discussed the previously in there are chances of the posterior placenta, or we need to opt for the intrahepatic in case of the anterior placenta through the intra umbilical can cause the bradycardia also. It can cause if the IOD, if the overload is there, so we can, and we need to paralyze the baby or for the fetal movement.
Do you do it as a
fetal
routine?
movement. So there is a.
Do you do it as a routine, fetal paralysis?
Yes. We use the atracurium for that. If the placenta is posterior, and we need to go for the intrahepatic portion of the umbilical cord.
So the site for paralysis, atracurium injection.
The same puncture in the intrahepatic portion of the umbilical vein. When we take the blood sample, so before taking the sample, we can inject the atracurium in proper dilution, so the fetal movement is reduced and we can do the procedure smoothly.
Thank you. So next case in our.
Karuna, can I interrupt you?
Yes, ma'am.
We have shortage of time. You take the questions from the audience. They have put around 10-15 questions are there, very interesting questions. So we solve their problems and afterwards, because the time is short. So you just.
So we stop the panel discussion as of now.
Okay, thank
Yeah,
you.
I think because it is 5:45.
Thank you so much.
Questions.
Thank you, Karuna, for informative panel discussion.
Thank you.
Sure. So you take that question, Sati.
So
Mr. Session,
the chat.
you just put that chat box. I think questions are on the chat box.
Yes, madam. They're there in the chat box.
So I can see from question 9. I can't see the previous ones.
Session, can you put all the
Session? I can see from the question 9. Let me start with question 9. By that time, or if you can forward me on the WhatsApp.
Yeah.
I'm not able to.
Ma'am, you can scroll up.
I'm trying, but I'm not able to. I can scroll down. I cannot scroll up. Fine.
Ma'am,
Let us
the
take it
first
from question 9. Yep. Or otherwise, you can tell me the question.
The first question is, does all primary gravidas need to be tested ICT routinely?
So that goes to Dr. Dara.
Yeah, ma'am, I think so. Yes, it is.
Okay. Practically, is it feasible?
Dealing with
Leela
ICT.
ma'am. Leela ma'am. Practically feasible?
No. Only we are doing for RH negative. And Ravi, if you can help us in RH negative, we'll be more than happy.
Fine. So let's take the second question. Second question.
Should we give NTD in threatened abortion without pain and non-recurrent bleeding? Medical treatment of ectopic or medical abortion?
This we have already discussed. Any pregnancy-related bleeding, they are to be covered.
Can I ask, Savita, I can ask you one thing. You have gone through the literature. Is there any evidences that how long the bleeding is occurring with the medical abortion? Because the patient comes with the bleeding up to the months together. Is there any effect of that bleeding on insemination? Savita.
Ma'am, I have reviewed the literature and they have written that in medical abortions, because we are doing abortion before 7 days and we are not doing surgical curettage, so chances of fetal hemorrhages are very, very low. And but theoretically, there can be chances of sensitization, so we can choose the
Hello.
informed consent. You can give NTD, but duration of bleeding has no correlation with the amount of.
Any evidence of retained products? If it is a prolonged, then is there any chances of that? Because these are the common questions asked by everyone.
The uterine cavity only. And many
मैं सना से दोपहर को कंफर्म किया, मुझे सब स्लाइड्स मिल चुका है सबका.
because the availability of NTD is there.
I'll check with her. I just spoke to her. She asked for one CV. I've given her that one CV.
One more issue in our country which we have not addressed, that we have a genetic heterogeneous population. Heterogeneity. And Madam Leela, ये मैं आपको ही request करूँगी कि जयपुर में monoclonal antibody available है, which is called Roclone. पहले रोगैम आया करते थे, which is polyclonal. और हमको patient को polyclonal ही चाहिए. I am doing coronary blood sampling जिसमें मैं needle उसमें placenta में डालती हूँ और मुझे पता है polyclonal ही देना चाहिए, but मैं patient को बोलूँ तो कैसे बोलूँ?
The availability is not
problem. It is not available, though we know that we need polyclonal. So इसलिए
we'll work on that. Definitely.
RH negative sensitization के cases in spite of giving NTD, they are more. एक रीजन तो ये कि हम वो नहीं कर रहे, फीटोमेटल हेमरेज को नाप नहीं रहे हैं. दूसरा कारण मैडम ये भी है कि हम लोग मोनोक्लोनल एंटीबॉडीज यूज कर रहे हैं. उसके कारण इन स्पाइट ऑफ गिविंग एंटीडी we are getting sensitized pregnancies.
Yes.
So in that scenario,
so many literature, the evidences are there. The polyclonal is required for that.
And फिर उस सिनेरियो में अपने को मेडिकल अबॉर्शन में एंटीडी पे कितना जोर देना है, we have to decide.
Yeah, definitely. So anyone can do the study on that. After the medical abortion, how much the
there are trials, there are literature is available.
Yeah, available.
हमारे ICMR में डॉक्टर सुनीता मित्तल ने किया है इस पे काम, and they have given the guidelines in their booklet that in medical abortions NTD is not needed.
But because we practically see that patients are coming with that, even with the medical abortion, primarily those who have taken without asking anyone, over the counter they have taken and they are coming positive.
Maybe they have taken many, they are saying, the literature says that if it is a primary gravida, unmarried girl, the future pregnancies she is going to have, then please give NTD.
Yeah, definitely.
Because theoretically there is a risk, but if somebody is third gravida, second gravida, not going to conceive.
That is a totally different thing. That is totally different thing. But in the primaries, because this over-the-counter medication are taken by so many primary girls, and nowadays as the unmarried girls they are taking, and even the married, those who are postponing their families, they very common.
Finally, as of now, ma'am, till we do not have these studies.
Polyclonal available कराना है मैडम, आप ही करा सकते हो.
Till we do not have, it's better to over-treat, ma'am, than doing IUTs.
Yes.
So coming to the next question. What is the time to give anti-D in ANC cases that we've already discussed? What is the dose of anti-D in twin pregnancy? Question is open to all. Anybody?
Prophylactic to dose same ही है. Prophylactic dose is same.
But again,
we
have to check in then.
Ideal is quantification. Till Ravi is not starting, we will over-treat rather than under-treat. What is the, should we give anti-D in threatened abortion without pain and non-recurrent bleeding, that we have already discussed. How to proceed in Coombs test positive mother at 20 weeks. We discussed that if Coombs test is positive, antibody typing has to be there. And then you have to follow the gold standard is MCA-PSV, wherein not only MCA-PSV, in total you have to monitor the baby. And whenever you're sending your patients to radiologist, please keep an eye on the whether they have done the angle correction. Otherwise, you will have, these blood banks we have, and they do the antigen typing, and accordingly they provide us blood. At least we are getting from Manipal. Dr. Ravi, thank you. In case of APH bleeding and on throughout pregnancy, how many times she requires NPD? Again, Dr. Neil in her talk also she answered that 6 weeks it covers. So once you have given, and then if it bleeding off and on is there, then in that case you might have to repeat after 6 weeks. What to tell the patient if her ICT comes to be positive at 6 weeks and she has previous losses? From Dr. Mandeep. So who would like to answer? Anybody?
Yeah, definitely the counseling is very important.
She has.
Yeah.
Hello.
At the 6 weeks, Miss, she
Yeah,
has already
ICT is positive,
the counseling
then-
is very important.
Yeah, she
and then the proper monitoring, and then the further antenatal management is required. So it should not be overestimated that you will get all the things. So proper counseling, which will give, and again then we have all experts here, so we can send them and then manage accordingly, and then only this.
Thank you, ma'am. Thank you so much. So
We
that
have-
means we don't have to scare the mother. We have to tell her that don't worry. We have options and we have to keep her in close surveillance. Some
Yes.
sonologists have given NCA PSV in unit of velocity only. Is it correct? If they have given in the terms of PSV, centimeter per second, that's okay. You can yourself put in the charts. They are available online free of cost. And a very simple formula is gestational age in weeks, double it up. If the NCA PSV is more than that, then she needs a transfusion. Generally, 1.5 MOM is double of the gestational age. So if they have, you can request them to give in mom values. If you are not giving, then maybe you can do it yourself. Can you tell where the Rosette and KBS tests are done, Dr. Kalpana? As of now, it is not done now, but then we will be starting soon. Thank you. Causes of hydrops fetalis other than Rh negative incompatibility. Madam, hydrops fetalis it itself is a big topic. Whole list, full page list of the bigger book. It's there. The parvovirus and the angiomas and hyperdynamic circulations and the aneurysms and all. So it's a long, long list. So please leave it up to the fetal medicine people to look for all those things. What is the harm of giving higher dose of 150 to 300 micrograms of Rogamin first trimester option? Over treating is always better than under treating. Thank you. Anything else I am leaving? Question. Patient with anti-D titers 1 in 312 checked twice with NCA PSV normal and no feature of hydrops. Do these values really match with each other, and how do we proceed? Dr. Mamta Gupta. Who would like to take this question? Dr. Manu?
No, Dr. Ravi is going to take. Ravi?
Yeah. Ma'am, first of all, these titers are wrong.
Huh.
First of all, these titers are wrong.
First of all, titers are not actually appropriate. It is in the multiples of 4. So
Yes.
I think so the repeat check is more important.
yes, 128 and 256, and then 564 can.
But then the thing is,
And second thing, titers does not match.
Doesn't
If
match.
ICT titer is hello.
yeah, please tell me.
Yeah, if ICT titer is very high, it just indicates that the mother is isoimmunized. It does not very well.
The effects may come later on. The pregnancy has to be followed carefully.
Yes,
One
it does not
important
correlate
thing-
very well with the NCA PSV and fetal hydrops, features of fetal hydrops. So it has to be always the ultrasound which should be followed up once the ICT is positive.
Why? Can you please explain?
Hello?
Why? Can you please explain why doesn't it match?
Yeah, because ma'am, the titers antibody, the level of the immunoglobulins or antibodies which are circulating in the mother could be high, but it is not the fetal cell destructions which is leading to the fetal anemia. So that is why they.
That was my question. Why it occurs?
All high titers do not cause anemias.
Why?
Sometimes anemias
Because it's simple. Like it's simply there is no way to measure the strength of the antibody. By titration, we are just measuring the quantity, not the strength. If you have a sulfuric acid 4% and if it is 0.4%, there's a difference. you don't have any way out to measure how strong it is to destroy. So that is why we have been discussing that once positive, MCA PSV is the gold standard to monitor.
Now,
so how to get parvovirus infection tested, Dr. Suman?
Titers are there to label it as RH sensitized pregnancy and to be followed then with MCA-PSV once it crosses the.
Correct.
Now, Karuna, we can stop here.
Yes, ma'am.
Now I call upon our the society secretaries, Dr. Sangeeta, Dr. Savita. Where is Akriti?
Ma'am.
Hello, Savita.
Ma'am, can I take 2 minutes because I had repeated request for the plasma pheresis thing, and that was my last case. So if there are very high titers, though they are very rare, I had one patient more than 1 in 4,000. Dr. Ravi and I had dealt it. What are the treatment options for very, very high titers?
Yeah.
And when the titers are so high that they damage the baby without before we can do any kind of IUDs. Dr. Dara, would you like to throw light on that?
Yeah, when the titers are high, and if it is only a single antibody or a multiple antibody, hardly matters. We can go for a plasma pheresis, and it can be planned accordingly. Like it will be a fortnightly initially, then it will be a weekly part as the pregnancy progress. And along with this, not only plasma pheresis, we have to give the IVIG also.
Ravi.
Yeah, ma'am.
Do it in pregnancy, ma'am.
You
We
do
had
it
one
during
case.
pregnancy or before?
The last case was that one. In
You
pregnancy.
do plasma pheresis during pregnancy or before?
No, ma'am. During pregnancy. During pregnancy.
During pregnancy. Any gestational age?
Yeah, you can go and no problem for that. We have done a one case here in Jaipur only in second trimester.
Is it not dangerous for the pregnant?
Not at all. Not at all.
We
Not
could
at
save
all.
one
ma'am.
baby like that. We could save one baby like that. Thanks, Dr. Dara. With his help,
And we have now upgraded option also. We can do a cascade plasma pheresis where we don't have to give any plasma from outside. It's just a filtration medium. And at least we are actually doing for the renal transplant cases, and similarly we can do it for the pregnancy aluminized patients also, the same thing.
Therein, madam, IVIG again has a good role, but then it becomes expensive. So the case we did, the patient was not affording for IVIG, the dose what was required. So we did only plasma pheresis, and we could take the baby to term and we could save the baby. Though unfortunately because of some other complication the baby succumbed. But then with plasma pheresis, the titer was really high, more than 1 in 4,000, right, Dr. Ravi, if I remember? And we could save the baby. So, ma'am, thank you so much. So I just tried to cover things of the requested things. Thank you so much.
Thank you very much for covering everything. And thank you all panelists for sparing your time. And Ravi, really, thank you for you.
Thank you.
Notice yesterday afternoon, just I called you and you got given your permission, and thank you very much.
And Dr. Leela.
From all the societies, now you just give your feedback.
Okay, one second I want to say, Dr. Leela, it was a wonderful panel, very beautifully moderated by Dr. Karuna, and I would love to have Dr. Karuna's number and Dr. Ravi's number. Please send to me.
गाजियाबाद
We are in the group.
गाजियाबाद भेज देते हैं.
मैम गाजियाबाद जयपुर लेके आएंगे.
बुलाना पड़ेगा.
चलिए सविता और संगीता.
वेबिनार से मैम इतना इजी हो गया मैम, आपसे मिले बड़ा अच्छा लगा और इतना अच्छा डिस्कशन किया मैम.
गंगानगर आना नहीं पड़ता मुझे.
मैम घर बैठे ही सब कुछ मिल रहा है तो कितना बढ़िया हो गया.
मतलब फिर अब ना सब लोग थैंक यू कोरोना को ना कहने लगे कहीं.
देखो पूरी बुराई में भी कहीं ना कहीं अच्छाई होती है.
ये तो सही है.
थैंक यू वेरी मच.
Thank you, Leela ma'am. Thank you, Karna madam. Nice panel discussion, and thank you very much, everybody.
Thank you.
I think 400 delegates have joined this webinar. So it's a good number.
Thank you, Leela ma'am, for giving us this opportunity.
Dr. Savita madam, thank you.
Ji madam. Thank you madam.